We will now next call upon stage Dr. Zofia Anna Nawrocka, our keynote speaker of this session. She is professor of ophthalmology in Lodz, Poland, and she will be talking about ILM peeling in macular hole surgeries.
Ladies and gentlemen, first of all, I would like to thank Edana Shiratra and the organizing committee for inviting me to be here with you. To tell you the truth, I will tell about how to avoid ILM peeling and what's new about the inverted ILM flap technique. So when we first introduced the technique, we peeled the ILM from all around the fovea in order to put the ILM on the top of the full thickness macular hole. As you can see here in this surgical video and animation. Since that time, more than 150 modifications of this technique were already published, and it's really difficult to look through all those techniques. But the only modification that was confirmed in a prospective comparative non-randomized interventional study is the temporal inverted ILM flap technique. It's a surgery in which we peel the ILM only from the temporal side of the fovea in order to cover the full thickness macular hole. With that, I usually use a membrane blue staining and then create a flap from the temporal side of the fovea. In this manner, we can avoid destruction of the nerve fiber layer on the nasal side of the fovea. I never push the ILM into the hole. I just gently cover the hole with the peeled ILM flap. And now I would like to ask you an apparently easy question. What does it mean that the surgery you made was failed? It is very easy for us to tell if we encounter such an image. It is a really full thickness macular hole, a failed surgery, and it's not to be discussed about. But what about this? This is the type 2 closure described in the literature. In this type of closure, we observe the bare retinal pigment epithelium and flat margins of the full thickness macular hole. In many papers concerning large or long-standing macular holes, the surgeons note 20 up to 40% of such a closure appearance. And many people describing it in the literature estimate it as surgical success, which is apparently not. So the inverted ILM flap technique was not only designed to improve functional and anatomical results in large complicated macular hole, but of course to avoid as well the type 2 closure and to revert the type 2 closure into a normal fovea appearance. So the inverted ILM flap technique was earlier published to be successful not only in large idiopathic macular holes, but in a plenty of different indications. I will talk with you in a few moments. But what about the results? As you can see, in idiopathic large macular holes, the technique is superior by about 10 to 15%. But if we include the cases of type 2 closure, the difference between ILM peeling and the inverted ILM flap is even higher. Another indication besides the large idiopathic macular holes, which was published, are highly myopic macular holes, in which probably the inverted ILM flap technique should be nowadays the technique of choice. And now if you look at comparative studies comparing ILM peeling and the inverted ILM flap technique in high myopia, you can see that the difference in the anatomical success rate reaches even 70%. Looking at the visual acuity, you have to bear in mind that most authors presented only visual acuity of closed cases, so that is not the real difference. Another indication to use the inverted ILM flap technique, which is rarely talked about, is our full thickness macular holes coexisting with diabetic retinopathy. Of course, they have worse results when compared to literature to idiopathic full thickness macular holes. We observed in about 30% of cases of full-thickness macular holes coexisting with diabetic retinopathy, some hyperreflective remnants on the top of the fovea. We do not have to worry about them. We observe them also in idiopathic cases, and they are not associated with worse visual acuity. The fovea morphology of full-thickness macular holes coexisting with proliferative diabetic retinopathy is very similar to that observed in high myopic macular holes. So the minimum to maximum diameter ratio is much higher than in idiopathic cases. Full-thickness macular holes might also be associated with dry AMD. Here also the inverted ILM flap technique might be successful, but of course the functional result, the final functional results will be worse than in idiopathic cases due to the underlying disease. We observed that after surgery, in some cases, new drusen appeared, but also drusen can decrease after vitrectomy. That was also observed by other authors, and that is probably due to phagocytosis of drusen after removal of the posterior hyaloid. I would also like to share with you a case of a woman treated with anti-VEGF for choroidal neovascularization in neovascular AMD who developed a full-thickness macular hole. In this case, also the temporal inverted ILM flap technique was used. As you can see, the ILM is stained with membrane blue and inverted gently in order to cover the full-thickness macular hole, not pushed inside. As you can see, we obtained the closure of the macular hole immediately after surgery, and the patient was further treated with anti-VEGF injections. You can see that the neovascular underlying disease reappears for many, many years, and the patient is further treated. Now coming to some tips and tricks. When the flap is sticky and it's quite difficult to position it on the top of the fovea, still don't push it inside. I usually use Helon to position it gently on the top of the fovea, as you can see here in this video. The Helon does not need to be removed at the end of surgery, and you can position the flap with that quite easily. So what about the flap closure? Doing the inverted ILM flap technique, we observed a new closure type, that is closure of the full-thickness macular hole with a thin layer of the inverted ILM. It will recover in the future, probably those eyes closed with the inverted, only with the flap closure. Those eyes would end up with the type 2 closure if we would have done the ILM peeling alone. Now coming back to the remnants of the ILM, also we shouldn't worry about them. We performed a study and proved that it is not influencing the final visual acuity. And now about putting the ILM inside the hole, there is also a study published telling that in both macular holes with and without coexisting retinal detachment, the functional results are worse when we push the ILM inside the hole, and that's a clear evidence that we should only position it on the top, as we published from the beginning. About the mechanism of action was also already confirmed by a Japanese group. We suggested that the ILM might serve as a scaffold for tissue proliferation, and Japanese colleagues proved it to be true on monkeys. So if the inverted ILM flap technique is so successful in difficult cases, the question is, why shouldn't we do it in small macular holes? And there are actually a couple of studies confirming that this is a good idea and that there is less foveal gliosis when compared to ILM peeling, and that the regeneration of the interdigitation zone and the external limiting membrane is quicker when we use the inverted ILM flap technique when compared to ILM peeling alone. There is one study suggesting there might be a lower macular sensitivity, but another authors confirmed it in much more detail, and they described that the macular sensitivity is only lower in the ILM peeled areas, whereas in the areas of where the flap is inverted, the macular sensitivity is quite good. Peeling the ILM only from the temporal side saves the retina nerve fiber layers, and as you can see here in this publication, it has also some influence on saving of the deep retina vasculature. Here you can see signed out by the arrows that the retina vasculature is worse in the deep retinal layers in Webster's OCT angiography in the ILM peeled area. What about spontaneous closure? We published a study in which we confirmed that, of course, it can happen in about 3% of cases. Even in large macular holes, we can encounter spontaneous closure, but the final mean visual acuity is not superior to that which we would obtain by surgery. And not all for the architecture types. After spontaneous closure ideal, you can see that sometimes lamellar macular holes can develop. And this is a patient who encountered 2 spontaneous reopenings and 2 spontaneous macular hole closure in the last couple of years. The first spontaneous closure was 5 years ago. And here you can see the macular hole that reopened for the 3rd time. And the surgery that was performed last year. I performed staining of the ILM with membrane blue. I performed core vitrectomy and tried to create a flap, but as you can see, the tissue that I'm touching is quite different from normally appearing ILM. So I double stained the tissue, and you can see here is a negative staining for the epiretinal membrane, and I try to create the flap of the internal limiting membrane nearby. Of course, in some cases where you cannot separate the epiretinal membrane from the internal limiting membrane, you can create a flap of both tissues, but here it's a rare case, not only rare because of this spontaneous closure, but also rare because it's succeeded to remove completely the overlying epiretinal membrane, which is also a negative prognostic factor for final visual acuity, and to create a temporal flap of the ILM after complete epiretinal membrane removal. In such cases, I try to avoid performing peripheral vitrectomy, which I will explain you in more detail tomorrow, and only to perform core vitrectomy and create this flap, not pushed inside, but only positioned gently on the surface of the full thickness macular hole. In this case, as you can see, we obtained very successful macular hole closure. And now coming to the question, what about repeated surgery? If we perform the ILM peeling as the first surgery, we can encounter even up to 40% of failures, including type 2 closures. Of course, we have a lot of techniques enabling us to repair macular hole surgeries failed in the first attempt when ILM peeling was used, from the autologous ILM to amniotic membranes, subretinal injections, or capsule transplantation. Those techniques are quite difficult and are not associated with high final visual acuity. Here is the OCTs after such surgery. Of course, if we do the inverted ILM flap technique, we also can observe failures. About 5% of large full thickness macular holes might also be failed with the inverted ILM flap technique. Coming to surgery, the repeated surgery in such instances is for me also the confirmation that the inverted ILM flap technique should be done in every case, because repeated surgery, as you see, is very easy. Just restain the ILM, and you can see that the surgery was failed due to the fact that the ILM flap returned to its original position. I just reinverted the flap created during the first surgery. We can position it with some viscoelastic material. During repeated surgery, we can use either, again, air or silicone oil tamponade. Here is a patient sent to our clinic with 2 failed macular holes. In the right eye, the primary surgeon peeled the ILM completely, so I restored the fovea with an amniotic membrane transplantation. And in the left eye, the primary surgeon happily did not peel the ILM, so during the secondary attempt, I closed the fovea. As you can see, both macular holes are closed, but visual acuity is far better in the eye where I did repeated surgery with the temporal inverted ILM flap technique. So as a conclusion, I would like to state that the temporal inverted ILM flap technique improves anatomy and function in large complicated macular holes. It can also be used in smaller cases, and repeated surgery is very easy if we perform the inverted ILM flap technique in the first instance. Thank you very much for your attention.
Thank you, Dr. Anna, for the wonderful videos and a very insightful talk.